evening all and everybody. So my topic for today for the discussion is echocardiography as point of care basics and beyond for all. So the first thing I like to say is if you really don't look, we don't know. And why do I say that? Say a 21-year-old student who had an RTA, he complains of severe right leg pain and most commonly diagnosed as right femoral fracture, GCS 15/15, bruising marks seen over the chest and right leg. But when the general anesthetist take him up for a right femur fixation, his BP on monitor shows 90/50 and heart rate around 68. So I guess if you put up echo and why this BP is not only the blood loss, because there has been no obvious blood loss. So if you put in an echo probe, we get to see this. So that's a huge pericardial tamponade. We can see a tamponade around the heart, and also there is an RV dilatation. So if someone sees this before taking him for anesthesia in the OT, then the whole anesthetic management changes. So that's why echo has been considered as a point of care ultrasound examination, and it's been performed at the patient's bedside and specifically very useful in acute clinical situations to aid in making a diagnosis or providing a qualitative assessment of a patient. Now, why do I say that? There has been also proved recently in 2014 in Anesthesia Journal, a review article was published, and it shows that a review of echocardiography in anesthesia and perioperative practice, its impact and utility. It was published by one of the registrars and intensivist in an UK hospital. And what they did was they looked into a lot of studies, and what they found is, like, say, Canty et al. Did observational prospective study of transthoracic echo in 100 patients who were posted for non-cardiac patients, and they found that when you're doing transthoracic echo, they had plan of management was changed in 54% of their changes. They had to either step up or step down in monitoring or in even the usage of drugs or plan of anesthesia. And what they did was mainly focus scan was done. So we don't really need to do extensive echocardiography for all patients. As anesthetists, not only as cardiac anesthetists, as any anesthetist, we should be having aware of this basic echocardiography, because this is one of the tools, or rather the pleasant eyes of anesthesia. We can actually change the whole plan. Even same study showed by Cowie, who also showed that same prospective study done in transthoracic echo for 170 non-cardiac surgery patient. There was significant change in management, around 82%, and also change in monitoring, like we may have to go for invasive monitoring instead of non-invasive. And the same measurement, like focus scan, was done pre-anesthesia. Even Schulmeier also showed that prospective observational study they performed in 42 patients who were posted for non-cardiac surgery. What they did was they did a transesophageal echo. Now, there is a difference that I would like to say. A transesophageal echo is an invasive procedure, though you really need a bit more expertise and you need more experience. But that doesn't mean that a general anesthetist cannot perform. You don't need to always have cardiac anesthetist around, and this is a much more better tool, but only constraint is you need more expertise and more number of patients you might be having practice over that. Similarly, Hoffer et al. Also proved that TOE for non-cardiac surgery elective patients, they had changes in plan. So all these studies, what they found and showed that echocardiography is a plan changer, and especially in acute conditions, obviously in any emergency scenario or any doubtful scenario, whether also patients posted in elective non-cardiac surgery, we should also, if you think that there is something wrong and you suspect, we should have a knowledge of transthoracic echo, and if we are able to do some basic screening, we may get a lot of knowledge and we may actually give a better outcome in this era for all the patients.